I'm Prabu Rau Sriram, working in Kota Kinabalu, Sabah as a consultant neurosurgeon. I have did my training in neurosurgery in Malaysia, in USM, and also in in Oxford University Hospital in Oxford, UK. So I did my fellowship in Paediatric neurosurgery and as well as open and endoscopic skull-based surgery, also in Oxford, United Kingdom. So embryonal tumors, as the name itself, it's a more of origin of embryonal cells. So in another word, it's the developing cells of the brain, or fetal cells, or we may call it. So, and embryonal tumors, if you look at the WHO 2021 classification, the new ones which is the fifth edition, medulloblastoma is one of them, and ATRT, and they have a few other various lesser common embryonal tumors in their classification. So, and the reason that it is more predisposed in this younger age group because of mainly the pathophysiology, if you look at it, and particularly like ATRT, there is molecular changes that is specifically associated with the like SMUG1 gene and in the chromosome 22. So these changes eventually also causes predisposition of the patient to the tumor, and this will start even in the times of antenatal, during the development of the brain in the womb. So this is one of the reasons we see these kind of embryonal tumors in a much younger age group. In the olden days, where we only have CT scan, this is I'm talking about pre-MRI era. These differences are mainly elucidated with more detailed CT scan imaging, clinical features, and as well as angiogram, diagnostic angiogram, which might give some clue in terms of tumor blush, and particularly in the setting of tumor, and then thrombosis in the settings of stroke. But in post-MRI area, MRI has significantly taken the burden off and has significantly helped us in differentiating in various instances. Diffusion in terms of differentiating stroke and tumor, diffusion images, perfusion images, in fact, MR spectroscopy. As all this will give us a clue in terms of is it a tumor origin and or stroke origin. For example, in a low-grade tumors, you might find the diffusion might not be so restricted, but in arterial stroke, there could be a significant restriction in diffusion. Also in spectroscopy, in an area of stroke, you might find lactate and might be raised, but in tumors, you might find, depending on the different grades of tumor or different pathology of the tumor, the spectroscopy finding may differ in terms of choline creatine ratio and other spectroscopy findings as well. So yeah, in that sense, the MRI is of significant help. Besides clinical features, of course, and then of course, that's always the first thing that we'll see. Acute presentation, acute short duration of presentation, which will suggest us more of vascular insults like arterial or venous stroke. If the question is depending arterial or venous stroke, then that is a totally also depends on clinical symptoms and the pattern of imaging in the CT and as well as MRI. Medulloblastoma, typically we see them when they come to me in my hospital. They do come at the age, after about 1 to 2 months of symptoms, and commonly since they are more posterior fossa, the most common symptoms would be imbalance, headache, and sometimes a bit later nausea, vomiting. So this interval between the onset of symptoms to the diagnosis, to the time that they present to us, in my personal experience, it does significantly associated with cultural background as well, especially what we face here. And those in the rural area with a bit more poor socioeconomic education status, they tend to bring their children later to the hospital. So that that symptomatic interval is a bit different from probably what we see in an urban area. So as for your question in terms of the prognosis or the outcome compared to the pre-diagnostic symptomatic interval, or we call it PSI, there's a few studies have looked into detail in it. One I saw was in European Journal in 2012. Another one's in 2004, particularly looking into medulloblastoma. So one found that there is no difference in the symptomatic interval with the outcome of survival. But interestingly, the other one found that a longer symptomatic interval has been associated with a lower, a better survival. So one of the studies they found, so medulloblastoma has been classified in WHO by according to molecular changes, and now they have 5 subgroups from wingless pathway to sonic hedgehog, group 3, group 4, and wingless pathway is one of the one that is associated with a better outcome, and they found that they found a mean duration of symptomatic interval of 8 weeks in this wingless pathway, which carries a better prognosis, whereas their overall mean interval is just 4 weeks. Yeah. So it is a bit too premature to conclude that this symptomatic interval, is it been associated, is it significantly associated with an outcome or survival? But what do we find is, I mean, in general, that if it is a slower progressive disease, then the symptoms do progress slower as well. So that gives time before the symptoms become worse, and the duration of the interval has become longer. But in those aggressive ones, they tend to progress very fast, even from the time of onset. Then that makes the interval shorter, for the symptomatic intervals shorter. So neuroglya2 is basically a type 1 membrane protein, or we call it NG2. It's a chondroitin sulfate proteoglycan. It's one of the antigen that we found in the membranes of the cells. When people tend to say NG2, they tend to refer either sometimes to the antigen that they found in the membrane, or sometimes to the cell itself, which expresses a high level of NG2. What they found is most of the cells that are expressing this NG2 is in eventually progress to oligodendrocytes. So these NG2 cells could be an oligodendrocyte, progenitor cells. In terms of its expression in adult tumors, it is pretty much well established, particularly in gliomas, and the expression is associated more in a higher grade gliomas found. And however, in pediatric age group, it has not been very much conclusive. There's no, but there's a few articles, few studies they have done retrospectively on analysis. And interestingly, what they found was they are not associated with higher grade tumors. In fact, out of 20 astrocytomas, they found only 9 are positive to NG2, and out of 14 medulloblastomas, only 2 are positive for NG2. So the whole significance of NG2 might completely differ between the adult and pediatric population. So we know that NG2 is a more of a tumor promoting protein, that it does promote vascularity for the tumor. And so consistently in adults, they tend to find NG2 expression, not only in the tumor cells, but also in the pericytes or in the vasculature of the tumor. But that is totally not there in the pediatric group of brain tumors. So the significance of it will probably completely differs from the adult and pediatric. So the prognosis of pediatric brain tumors depends on various factors. From the patient's factors, we can talk about the the age at presentation. So in general, we see those who come in younger age group, they tend to be associated with poorer survivals. When I say younger in terms of infancy, less than 1 year old. That is one. Even in medulloblastoma, before we have this molecular classification, in the risk stratification era, we used to classify medulloblastoma in the high risk age group with the age less than 3 as being in the high risk group. Besides the age, of course, the most important is a pathology. I mean, that's pretty obvious, isn't it? I mean, if you're talking about a higher grade tumor, definitely the prognosis is different compared to the lower grade tumors. And so grade 3 and grade 4, we generally tend to group them as those with higher grade and may carry poorer outcome. Besides that, the time of presentation to the medical care, if those who went to surgery, the incomplete resection of the tumor, particularly to tumors such as medulloblastoma or ependymoma, the incomplete resection does carry poorer outcome. And the other one is the metastatic. If you preoperatively you found metastasis, then either to CSF seeding to spine or the other parts of the brain, or even systemic, which is a bit rare in brain tumors, that obviously carries poor outcome too. No doubt, in some places in the world, they have been actively doing, and one of the areas that we probably would expect more advances to come in the future is in the area of targeted therapy. Let it be an adult or even pediatric brain tumors. So we're looking at, that's why this molecular identification of the tumor has become very important. And this is clearly, we see the changes in WHO classifications of brain tumors itself. Starting from 2016, things has been classified based on molecular changes in the hope that would better target the therapy for each of the tumors. Of course, besides that, also for the prognosticate outcome better. So these targeted therapies will eventually looking into these molecular changes or antigen expression. So these like monoclonal antibodies, which will target specific antigens. Like you say, we're talking about neuro-MG2 in adults, especially because it's commonly studied in adults. So if you target these proteins, we hope to have a more specific treatment plan for the patient, more targeted to the patient and patient specified, rather than a general treatment plan for all medulloblastomas. This is the treatment. I mean, that is fading away. We are looking into more targeted therapies nowadays. And in the future, I think this will more evolve. And molecular classification of tumors, molecular identification is the key for this. To be honest with you, I've had an interest in actuarial science at one point. I mean, this is I'm talking about in high school. That could be.